Welcome to session 3 of the Behavioral Health by Design series, Designing for Different Acuity Levels. I'm Dr. Melissa Steach, and I'm a PhD psychologist here at Pineapple, where our mission is to design purposeful solutions that enhance well-being in challenging environments. Now, throughout this series, we've explored the idea that environments influence human behavior. Today, we're taking that one step further. Behavioral health settings are not all designed to accomplish the same clinical objectives. A person arriving in psychiatric crisis requires something fundamentally different than someone participating in outpatient therapy or preparing to transition back into the community. So, rather than asking whether an environment is simply safe, we must take 2 steps more and ask ourselves, for whom is it safe, and safe for what stage of care? Today's discussion will explore how design should intentionally respond to different levels of acuity while supporting the dignity, recovery, and clinical goals of every patient. Behavioral health care is best understood as a continuum of care rather than a single type of service. In practice, organizations use many different service models and names. For today's discussion, we'll simplify that continuum into 3 broad levels of acuity. Each level reflects a different stage in the patient's clinical journey and, therefore, different environmental priorities. At higher levels of acuity, the environment is designed to support stabilization and safety. As patients progress, the environment begins supporting treatment while encouraging increasing independence. Finally, lower acuity settings focus on recovery and successful reintegration into everyday life. As we'll see throughout this session, the environment should evolve alongside those changing clinical needs. In healthcare, acuity refers to the intensity of care a patient requires. Higher acuity generally means greater clinical instability, increased supervision, and more intensive interventions. Lower acuity reflects increasing independence, greater emotional regulation, and preparation for recovery beyond the inpatient setting. The important point is that as patient acuity changes, environmental priorities change as well. Historically, behavioral healthcare environments have sometimes been designed using a one-size-fits-all philosophy, applying the same environmental strategies regardless of where someone is in their recovery journey. Evidence increasingly suggests that matching environmental characteristics to patient needs can improve safety, reduce stress, support staff effectiveness, and enhance therapeutic engagement. In other words, patient acuity should shape our environmental priorities. Those priorities should guide our design decisions, and together they help create environments that support trust, safety, and recovery for everyone that's involved in that care ecosystem: the patient, the caregivers, the staff, and the people who are visiting who have a vested interest in the patients there. And I just want to point out that the conceptual foundation for patient acuity, environmental priorities, design decisions that go into trust, safety, and recovery was informed by Donna Bedian's structure process outcome model from 1988. And in behavioral health care, patient acuity helps shape environmental priorities, the structure, which influence how care is experienced and delivered, process, ultimately contributing to outcomes such as the trust, safety, and security. And I just want to put a fine note there that if anyone, after any of these sessions, whether you're here live or you visit our YouTube channel and you look back at some of the previous sessions, if you contact me, I'm very happy to send you the PDF of all of the research citations. Just one of those nerdy notes for any of you fellow nerds like me. All right, so moving on. Now, high acuity environments are designed for individuals who experience acute psychiatric distress or behavioral crisis. At this stage of care, the environment must prioritize safety, observation, and rapid clinical response while still supporting a therapeutic experience. The primary clinical objective is stabilization. These settings often require continuous observation, rapid staff response, and environmental features that reduce opportunities for self-harm or aggression. Historically, safety has sometimes resulted in environments that feel cold, institutional, or punitive. Essentially, people preparing for the worst, which is understandable, right? If you put yourself in those some of those situations, if you've had the unfortunate occurrence and experience of something harmful occurring. Fortunately, research has shown that safety and dignity are not mutually exclusive, however. Simple design decisions, including access to daylight, reduced noise, calming color palettes, residential materials, and thoughtfully designed reduced ligature furnishings. And you'll know that I say reduced, not anti, because there's really no such thing as anti. Reduced ligature furnishings can reduce environmental stress without compromising safety. Importantly, those environments should help regulate the nervous system rather than unintentionally activating it. The environment itself becomes part of the de-escalation process here. Now, as patients stabilize, the environmental emphasis begins to shift. At this stage of care, the environment begins balancing safety with increasing autonomy, therapeutic engagement, and opportunities to practice the skills needed for recovery. While safety remains essential, the clinical goals expand to include participation, routine, emotional regulation, and skill development. Here, environmental design should begin restoring a sense of normalcy. Patients benefit from spaces that offer meaningful choices. For instance, where to sit, opportunities for privacy, access to communal areas, and environments that encourage positive social interaction. Research in environmental psychology consistently demonstrates that perceived control reduces stress and supports psychological well-being. Small choices like where to sit and whether or not to seek privacy or honestly whether or not to engage with other people in the moment can contribute meaningfully to recovery while still maintaining appropriate clinical oversight. The environment gradually transitions from crisis management toward therapeutic engagement. And also another point here is that in psychology, autonomy isn't an all or nothing state. According to self-determination theory, which is a really well-known theory, and also organizational psychology, autonomy is a fundamental psychological need. It exists on a continuum. So a patient in an inpatient behavioral health unit may have very little independence, but they can still experience autonomy through choosing again where to sit, whether or not to participate, selecting a quiet space, personalizing their room, or deciding where to spend time alone versus with others. And these are just some examples of supported autonomy that are not so expensive or difficult to implement, especially if they are designed beforehand. Lower acuity environments often represent the next stage of recovery. And at this stage of care, the environment should support autonomy again, belonging, comfort, and reconnection with everyday life. Here, design should communicate hope and competence and dignity. This is where patients begin to build their self-efficacy muscle. And these settings increasingly resemble familiar everyday environments rather than institutions. So warm material, hospitality-inspired design, natural light, comfortable furnishings, artwork, and opportunities for social connection can help reinforce the message that recovery is possible. Environmental cues also influence identity. When spaces feel welcoming and connected to the community rather than overtly institutional, patients may experience greater comfort. They feel less stigmatized and have a stronger feeling and affinity for engagement with the treatment. The environment begins supporting not only clinical care, but also recovery and reintegration into everyday life. So again, according to self-determination theory, if we look at building this self-efficacy and this sense of normalcy and competence that one can take care of and manage themselves, then we're looking at examples like having patients manage their own schedules, navigating the community spaces, making treatment decisions, exercising some personal responsibility, and living independently. And again, these are all examples of self-directed autonomy. So as we go through this, you might notice that none of these environments abandon safety. And this is important to note because the role of the environment evolves as the patient needs evolve. Higher levels of acuity, the environment emphasizes safety. Again, the observation and rapid clinical response. Safety is primarily a concern, and it anchors everything in the design for all of the people who are participating in this caregiving space. As patients stabilize, the design begins supporting greater autonomy, therapeutic engagement, and opportunities to practice those skills needed for recovery, but still in a very safe environment. And then at the lower acuity levels, you're looking for the environment to increasingly support that sense of belonging, to really enhance and boost confidence, and to facilitate successful reintegration into everyday life, and still with a sense of safety across the board. Psychological, physical safety is important for everyone in this caregiving experience. And so this progression really reflects an important principle, which is the environment should be supporting everyone along this stage. And when we design every behavioral health setting the same way, we miss opportunities to better support the unique clinical goals of each stage of care. And sometimes the design can really be communicating and therefore subconsciously going against the very therapeutic model that the system or that caregiving space is trying to apply. So it's about an alignment of and a lowering of friction so that the messaging that is being verbally given, visually given, and intangibly felt is all working hand in hand to create a very successful, very positive, and effective caregiving system. All right, so on the screen here, throughout our session, we've explored how patient acuity shapes environmental priorities, but while those priorities evolve across the continuum of care, the design philosophy should continue to go with it. So whether we're designing an emergency psychiatric assessment space, an in-person behavioral health unit, or an outpatient recovery setting, we're ultimately working toward the same outcomes. The Design for Dignity framework provides a practical way to think about achieving those outcomes. Rather than focusing on individual products or isolated design decisions, it reminds us to consider how the entire environment supports therapeutic care. So let's look at this a little more closely through these three design considerations. First, at the center of the framework, we have the outcomes, which are ultimately trying to achieve the trust, the safety, and recovery that we've been talking about. And those are supported through three complementary design considerations. We have the therapeutic environment going from the bottom up, and this includes elements such as materials, lighting, acoustics, ergonomics, which gets left out of the equation a lot, and I would like to broaden that to macro ergonomics to include the physical, the mental, and the social, or sometimes emotional, depending on the model you're looking at, ergonomics of people in space, and overall comfort. And together, these design decisions influence stress, emotional regulation, attention, and our sense of psychological safety. And research in environmental psychology has consistently shown that our surroundings shape how we think, feel, and behave, not just aesthetically, but physiologically as well. And this extends beyond behavioral health into the workplace. There is research that has shown that people subconsciously know within 7 seconds of entering a workplace lobby for an interview whether or not they want to take the job. That's powerful. So then if we extend that to a more, let's call it a more intense experience, and feeling of what behavioral health means. How strong is that first impression? Then we have behavioral health care environments that must have strength and durability. They must be able to withstand extraordinary daily demands. Materials and furnishings need to perform reliably while maintaining a welcoming residential character. Durability isn't simply about longevity. It supports consistent operations. It reduces maintenance disruptions and helps preserve the dignity of the environment over time. And this really impacts the staff as well, not only from a utility and function point of view, but also from a sense of employee engagement and a sense of pride in where one works. And then finally, we have safety and risk reduction. So behavioral healthcare settings require thoughtful approaches to reduce ligature design, anti-tamper construction, climb resistance, and minimizing opportunities for concealment or weaponization. These features help protect both the patients and staff while allowing care to occur in environments that feel supportive rather than punitive. And the most successful behavioral health care environments don't force these priorities to compete with one another. Instead, they integrate them. When therapeutic environments, durable design, and thoughtful risk reduction work together, they create environments that support trust, promote safety, and ultimately contribute to the recovery. Now, today we've explored how behavioral health environments should respond to different levels of acuity. While the specific design strategies may change across the continuum of care, the underlying objective remains remarkably consistent. Creating environments that support trust, safety, and recovery is the focus of the space. And the Design for Dignity framework reminds us that effective behavioral health design is never about a single product or feature. It's about intentionally bringing together these therapeutic environments to support the patients and the people who care for them. Now, in our next Insight series, Trauma-Informed Interior Design, we'll shift our focus from where care is delivered to how that environment is experienced. We'll explore how design can influence stress, emotional regulation, perceived safety, and the everyday experience of the patients, families, and staff. And there's some really encouraging evidence, particularly coming out of the empath model and empath units that show that there's a very different way of approaching crisis stabilization and de-escalation that is effective and humane, and it is positive, mostly positive for everyone involved. Now, if this topic is interesting to you, we're offering an IDCC accredited continuing education program entitled Design for Trust and Recovery, Evidence-Based Design for Behavioral Health. And this CEU takes us much deeper into the research behind behavioral health environments to explore practical design strategies that architects, designers, and facility leaders can apply immediately. We'd love to continue the conversation. And here's our team all throughout the US and Canada. So whether that's through CEUs, projects, or just exchanging ideas, please feel free to reach out to the person in your region, or you can always use me as a point of contact. And I'm very happy to to connect you with the person who can best support you. So thank you. And remember that together we can design environments that truly support recovery and resilience. We look forward to welcoming you again at our next session. Take care.